So in order to set the diagnosis in patients with AL amyloidosis, we need to have a target or a surrogate organ biopsy, which demonstrates the presence of amyloid. And we have been increasingly using surrogate target tissues, which includes a bone marrow aspirate or salivary gland. Other surrogate organs are a bone marrow biopsy, where we can find the amyloid. And this avoids many times the complications that are associated with trying to biopsy target organs, which means the kidney, the heart particularly, which is quite difficult to biopsy, or the gastrointestinal system. And most centers will try and set the diagnosis by biopsying a surrogate organ, like taking just a fat aspirate, which is quite simple. But in a proportion of patients, approximately 24%, you will not be able to find the amyloid in the surrogate tissue. No, you will have to go to the target organ. It seems that from the data that we presented in our poster, that when you find amyloid both in the bone marrow and the fat aspirate, this is associated with a worse prognosis for the patients, which probably is reflected by a higher burden of disease. So you have more amyloid, it goes to the bone marrow, it goes to the fat aspirate, and this is how the two are linked. And hopefully we will increasingly be using surrogate tissue biopsies in order to set the diagnosis, to try and avoid the complications associated with trying to biopsy the heart or the kidney for these patients.